Hi, I'm Jean Riddell, and I'm going to be talking to you about dermal punctures. So we're going to start with the Phlebotomy textbook, Chapter 11, Dermal Punctures. A dermal puncture is not used as often as routine venipuncture. It is, however, the method of choice for infants and small children who do not have large enough veins. Dermal puncture is also the method of choice for collecting samples for point-of-care testing, such as blood glucose, for diabetic patients. Dermal punctures also allows a smaller amount of blood to be collected from premature infants to prevent iatrogenic anemia from occurring. Iatrogenic anemia means the anemia is caused by collecting too much blood for testing and is a risk for premature infants who are very small. It is important to collect an adequate sample of blood using a dermal puncture. The small volume can lead to a higher risk of contamination from the skin and from tissue fluid. Microclots are small clots that can form if the procedure takes too long. Hemolysis can occur if there is excessive squeezing, the alcohol does not dry before puncture, or the collection tube is mixed too vigorously. This is the method of choice for newborn metabolic screening tests, which only require a small amount of blood. If a sample comes from a dermal puncture, it is important for the lab to know the source, as the lab values may vary from a venipuncture. If a physician needs to compare results over time, then the sample should come from the same source to reduce variability. The concentration of glucose is higher in capillary blood than in venous blood. Concentrations of potassium, protein, and calcium are lower in dermal puncture samples. Arterial blood gases will have different reference ranges due to the difference in values. Adult patients who do not have good venous access, such as those with scars, who have been given the chemotherapy, who have thrombotic tendencies, or have fragile veins, may require a dermal puncture on the third or fourth finger. If a patient is obese, it may be difficult to locate a vein, and a dermal puncture may be necessary. Some patients who are too afraid of venipuncture may be able to tolerate a dermal puncture, even though it usually is more painful. Dermal punctures are used routinely for glucose monitoring of diabetic patients using point-of-care testing methods. Point-of-care testing means the testing is done at the patient's bedside and not in the laboratory. If a patient is dehydrated, you may not be able to obtain sufficient blood flow. Blood from a dermal puncture comes from arterioles, capillaries, and venules, but the composition of blood more closely resembles arterial blood due to the pressure in the arteries. Warming of the area increases blood flow 7 times. The normal values in the laboratory are based on venous blood samples, except for arterial blood gases, which require an arterial puncture, which is performed by respiratory therapists. Arterial blood has a higher concentration of oxygen and lower levels of carbon dioxide than venous blood. Blood that is around the cells in the tissues is called fluid that is around the cells in the tissues is called interstitial fluid. This fluid can dilute a dermal puncture sample. Intracellular fluid is a fluid inside the cells. If the cells lyse, then this fluid can contaminate the blood sample and cause the lab values to be invalid. There are many types of dermal puncture devices. Most of these are automated so that the depth and width of the puncture is standardized and controlled. There are also many types of microcollection containers. The collection containers are also color-coded like the vacuum tubes are. The glass tube is used to make a blood film for viewing under the microscope. A glass slide is used to make the blood film for viewing under the microscope, but these are usually made by laboratory personnel from a purple top tube. A heel warmer should be used to increase the blood flow for an infant. If a heel warmer is not used, then the blood may not flow adequately enough to collect an appropriate amount of blood. The width of the puncture should not exceed 2.5 millimeters, and the maximum depth is 2 millimeters for heel sticks. If an infant is premature, a smaller depth should be used. The devices are color-coded to designate the depth. The automated devices will retract the blade into the device, but they must still be placed in the sharps containers after use. The device should be selected based on the age of the patient and the collection site, as well as the amount of blood needed. To produce adequate blood flow, the depth of the puncture is much less important than the width of the incision. This is because the major vascular area of the skin is located at the dermal subcutaneous junction. This is in a newborn is only 0.35 to 1.6 millimeters below the skin, but can be 3 millimeters in a large adult. The BD brand microcontainer contact activated lancet has a blue high flow with 1.5 millimeter width and a 2 millimeter depth. The pink is medium flow and the purple is low flow. The tender foot pink is for toddlers. Pink blue is for newborns, white is for premature infants, and the blue is for micro-preemie heel sticks. The quick heel is for premature infant heel sticks. The Tenderlet toddler, junior, and adult lancets, Unistick Tiny, Unistick 3, and Unistick and Bio 1 are other examples of dermal puncture devices. Of these on the slide, I have only used the Tenderlet. I didn't find it easy to use as the BD microcontainers that we saw on the previous slide, contact activated lancet. It is important to understand the color coding of the device that is used at your place of work so that you can select the correct type for your patients. Capillary tubes are also called microhematocrit capillary tubes. They can be used to collect a small sample of blood gases or for determining the hematocrit. The hematocrit is the percentage of cells in the blood sample. The image on the slide shows a sample of a hematocrit test from the medicallabtechnology.com. There are many types of small collection containers that can be used to collect blood from a capillary puncture. Those with anticoagulants such as the purple or green tops must be mixed. When collecting a microcollection tube, it should be slanted downward to allow the blood to flow toward the bottom of the tube. The collection tip should be placed beneath the puncture so that it touches the underside of the drop. You may have to mix the sample during the collection to prevent clotting if the process is too slow. Make sure you fill the tube to the required line, as tests cannot be performed unless the minimum amount of sample is collected. You may have to place small capillary tubes into a secondary container. Labeling requirements are the same as they are for the venipuncture tubes. A tube extender can be attached to some brands so that a full-size label will fit on the container. There are several types of microcollection containers that are available. The capillary tube with the flea in it and the red caps is for blood gases. The flea is a piece of metal that assists with mixing to prevent clotting in the heparin-coated capillary tubes. This slide shows additional examples of microcollection containers. Warming the venipuncture site increases blood flow 7 times. If you don't have the commercial heel warmers, you can use a glove filled with warm water or warm cloth. The temperature should not exceed 42 degrees centigrade. If it feels too hot to you, then it's too hot for the patient. This is an example of a commercial heel warmer. Always have the order ready before beginning the procedure. Make sure that you observe isolation procedures to protect the patient and yourself. Proper patient identification is vital in preventing medical errors. An adult should be seated or lying down with their non-dominant hand fully supported. An infant should be held by an adult or laying down on its back with the heel lower than the torso. Once a child has started to walk, the heel puncture is not advised and a finger stick or venipuncture should be performed. You should remember that the correct site for heel puncture is the medial or lateral plantar surface of the heel. Take care not to puncture the area above the calcaneus bone, or you may puncture the bone and cause a serious infection. Other sites of the foot are not acceptable as they may cause damage to nerves, tendons, or cartilage. Once a child is over 1 year of age or has started to walk, you should use a finger stick instead of a heel stick. Depending on the child's veins, venipuncture with a parent holding the child may give you a better sample and may hurt the child less. The puncture should be on the palmar side of the non-dominant hand on the third or fourth finger. Remember that the thumb is number 1. The puncture should be made perpendicular to the fingerprint, not parallel, to prevent blood from running. You should select the depth of the lancet based on the size of the finger. A heavily calloused finger cannot be used. A finger that is too small should not be used. Avoid the index finger to prevent nerve damage. Remember that you should not puncture through a previous site, a finger that is edematous, callous, scarred, cyanotic, or bruised. Do not collect blood on the side of a mastectomy without physician approval. Edematous means there is excess tissue fluid that will contaminate the sample. Cyanotic will look white or blue and there's not enough blood flow to that area. The same antiseptic that is used for venipuncture is used for dermal puncture, 70% isopropyl alcohol. The procedure is the same. You cleanse the area with the wipe, allow it to dry, and you do not touch it again. If you do not allow the alcohol to dry, you can ruin the sample or cause the patient to feel a burning sensation. After you have warmed the heel or finger and have cleaned the site, the next step is to massage the area. Hold the area to puncture, and then dispose of the lancet in a sharps container. You should always wipe away the first drop of blood, which can be contaminated with alcohol or tissue fluid. You should alternate between pressure and relaxation on the heel or finger. Do not scrape or touch the puncture site with the collection device. To avoid air bubbles in capillary tubes, hold it horizontal and slightly down at the end away from the collection site. It is difficult to fill a microcollection tubes and get a good sample for testing. It is especially important to mix samples with the anticoagulant to prevent clotting. The order of draw is not the same for dermal punctures. You start with capillary blood gases, blood smears, EDTA tubes, other anticoagulants, gray tubes, and then serum tubes such as red or gold tops. You will need to know both orders of draw by memory for your clinical rotations, your certification exam, and of course on the job. For bandaging, apply pressure and have the adult patient hold pressure and elevate while you label the tubes, then bandage. For an infant, you should hold pressure until the bleeding stops. Do not use a bandage on a child under age 2 as they are a choking hazard. If someone has sensitivity to bandages, you will want to use paper tape or just maintain pressure until there is no bleeding. The same labeling requirements apply to dermal puncture samples. First name, last name, date of birth, initials of the phlebotomist, date and time of collection. These images are of a heel stick. First, the phlebotomist is matching the requisition labels to the child's identification band. A heel warmer is applied. The heel is cleansed. A puncture is done with the appropriate size lancet on the lateral palmar surface. When there is an order for bilirubin testing, the sample is collected in an amber tube to protect the sample from light. This is done because light breaks down bilirubin and you could have a falsely decreased measurement. If the infant is under a UV light, it must be turned off during the collection. The sample must be collected at specific intervals to determine if it is decreasing as it should. Hemolysis will give you a falsely increased value. An increased level of bilirubin can cause brain damage, so it is important for doctors to monitor the levels if the child is jaundiced. An exchange transfusion may be required if the levels of bilirubin start to get too high. This will prevent kernicterus. Newborn screening for genetic, metabolic, or hormonal disorders is mandated. This is because early detection can prevent physical or mental disabilities if proper nutritional or medical intervention is started right away. This testing is done after the baby is 24 hours old, but before they leave the hospital. Phenylketonuria, or PKU, is caused by the lack of an enzyme that metabolizes the amino acid phenylalanine. The phenylalanine will accumulate and cause problems with brain development, resulting in physical, mental, and social skills delays. Early detection is crucial because the damage is not reversible, but the disease can be treated with a low phenylalanine and high tyrosine diet. Congenital hypothyroidism is a thyroid hormone deficiency present at birth. This can result in delays in growth and brain development that produce physical and developmental abnormalities which can be avoided using oral doses of thyroid hormone within the first few weeks of the infant being born. Galactosemia is a genetic metabolic disorder caused by the lack of liver enzymes that convert galactose, a sugar in milk, into glucose. Galactose accumulates in the blood and can cause an enlarged liver, renal failure, cataracts, blindness, and brain damage. Treatment is a lifelong elimination of all milk and dairy products by the patient. Cystic fibrosis is an inherited disorder caused by a genetic mutation that affects the transport of chloride across cell membranes. Secretions of thick mucus that are produced from this mutated gene build up in the lungs and organs of the digestive system, causing breathing disorders, infections, and malnutrition. Treatments include mucus thinning medications, bronchodilators, and antibiotics for infections. The patients have a shortened life expectancy, usually not living beyond the age of 30. This chart shows some reasons why a newborn screening sample would be rejected. If there is not enough blood, there are scratches on the paper, if it is not dried before mailing, or oversaturated by applying blood on both sides of the filter paper. Additional reasons for rejection include appearing diluted, having serum rings or clots. The possible causes are listed on the right side of the chart. This slide shows acceptable and unacceptable filling of the filter paper circles. Remember that the blood will usually be over the line and not exactly in the lines like this image shows, but the circle must be filled. This image shows proper filled filter paper sample for newborn screening. The sample must be dried before it is mailed.